Good evening, good afternoon, and it's really good to have you here with us. I'm Michael Moore. I am the chair of the International Task Force on Immunisation Policy for the World Federation of Public Health Associations. And we're running a series of training sessions, webinars that are about gender-neutral HPV vaccination. We really appreciate the support we get from the World Federation of Public Health Associations, from the University of Geneva, and from MSD. Without that support, these webinars would not be possible. So we've developed a comprehensive series of 6 online training sessions that are being done across the world in different places, in different languages. This one focuses on Asian countries, and so we have speakers who will discuss how this is all working and how they're going within their communities. And if I can have the next slide, please, Maria. And our speakers are Dr. Anthony Kalibo, Dr. Kataki Sharma, and Dr. Taifang Kwon. I'll start with Dr. Kataki Sharma, who's a senior medical officer in global and policy and global health terms at the National Centre for Immunisation Research and Surveillance. Her role providing scientific technical support to TAGI and the NITAG in Australia, and to global partner organisations via global health teams. In fact, she's actually coming to us from Manila, I think, this evening. And she's conducting research on the impact of biological immunosuppressants during pregnancy on infant and maternal vaccine immune responses. She's trained as a general paediatrician and has worked in child and adolescent health. So we're very fortunate to have her there here tonight. And we also have Pham Quang Tai, who's Vice Head of Infectious Disease Control in the Department of the National Institute of Hygiene and Epidemiology in Vietnam. He's over the past 21 years, he's had experience in his role as an expert on infectious disease surveillance. He has a Master of Philosophy in Public Health in Norway, and his PhD is from the United Kingdom. As one of the duties in his work, he also involved different stages of development, managing immunisation programs in Vietnam, working with both local and international organisations, as well as vaccine companies, to run vaccine trials. During the COVID-19 outbreak, he was part of the Rapid Response Information Team there in Vietnam. Our final speaker will be Dr. Anthony Kalibo, who's a paediatrician. He's a technical advisor for HPV. I don't know how you pronounce that, and I'm sure you're going to help me there. In the Philippines. Thank you. And for HPV Vaccination Acceleration Program Partners Initiative. He finished his Doctor of Medicine and later Pediatrics from St. Luke's College of Medicine and the William H. Kashar Memorial. His Bachelor of Science in Public Health from the University of the Philippines College of Public Health. He served the Philippine government in various capacities as a medical officer in 2007, a supervising health program in 2010, a specialist 2011 to 2020 in the Department of Health, and then he led the Child Health Division of the Disease Prevention from 2016 to 2020, and has been promoted now to Deputy Director of Food Nutrition Research Institute under the Department of Science and Technology. We're very, very pleased to have you all with us, and we really, really appreciate it. I'm going to begin now by calling on Dr. Kataki Sharma.
Thank you, Michael. So I'll just share my screen. Okay, just checking that looks okay.
Yes, it does.
Thank you. And just noting, I have no actual or potential conflicts of interest in relation to any of the material presented. And I'd like to acknowledge a number of my colleagues at NCIS, and as well as a lot of online resources such as the PATH compendium, which I drew on for this talk. So I'd like to talk to you briefly about the HPV vaccination experience in Australia, in particular, a little bit about the contribution to vaccine development that came from these University of Queensland researchers, the policy progress over time, our current vaccine program and coverage, and our progress towards cervical cancer elimination. And then just very briefly having a look at HPV vaccination globally. So what are the countries that have taken up gender neutral vaccination, which countries have taken up single dose vaccination, and a critical issue in relation to the ability to expand to gender neutral vaccination is available vaccine supplies. So, just having a quick look at the vaccines that are currently available and what's projected. So I won't read through all of this, but I just wanted to mention that in the University of Queensland in the 1990s, Professor Ian Fraser and Dr. Jian Zhao developed the HPV virus-like particle using recombinant technology in, I think, monkey kidney cells and submitted a patent. And that was really critical in the development of these highly effective vaccines. In 2007, Australia became the first country to roll out a national HPV vaccination program, and in 2013 expanded that to a gender neutral program. So this is the full policy timeline. So 4-valent Gardasil and 2-valent Cervarix were registered for use in 2006. Then in 2007, we had our national immunisation program, so nationally funded 4-valent vaccine for girls aged 12 to 18, with catch-up for women aged 18 up to 26, which they could access at their family physician. And that seems quite generous compared, I think, to some other countries. And just noting that there was a lot of political motivation. And interestingly, the Prime Minister's wife at the time had experienced cervical cancer. So it was a really important public health issue at the time. There was a school-based catch-up program initially, which was then ceased in 2008. And then the adult catch-up was ceased soon after. And then in 2013, the male adolescent vaccination started, again, school-based at 12 to 13 years, with a shorter catch-up program for boys aged up to 14 to 15. And then in 2017, catch-up expanded up to those under age 20, and that was for all national immunisation program vaccines. In 2018, we introduced the 9-valent Gardasil with a 2-dose schedule that replaced the 3-dose 4-valent Gardasil. And then the most recent change was in 2022, where we changed from 2-dose to 1-dose of the Gardasil, and catch-up was expanded up to the age of 26. And you can read more about the National Immunisation Program and about the specific HPV clinical guidance at the links below. So looking more specifically at the most recent change from 2022 to 2023, we now have 1-dose at age 12 to 13 for all boys and girls, and free funded single-dose catch-up for those aged up to and including 25 years of age. People who are immunocompromised with a specified number of conditions are also able to access funded doses, and select groups are recommended to have vaccination. For example, people living with HIV, men who have sex with men, and on a case-by-case basis, other adults may be recommended but not funded to have the vaccine. And this is just a graph showing you over time the age groups on the left-hand side of females who have been eligible. So it's not showing coverage, but just who has been able to access an HPV vaccine in Australia. Starting at the top, you see the initial years when it was introduced and then coming down towards 2018. And on the left, you can see obviously many more girls and young women have had access to this vaccine compared with boys, and that will obviously increase over time. And this is from our 2023 published Cervical Cancer Elimination Progress Report. So it's showing Australia's progress against the WHO indicators for their 2030 target. So you can see for cervical cancer incidence, the definition of elimination is fewer than 4 new cases per 100,000 females, and Australia is currently at about 6.4 new cases per 100,000 women in 2019. However, this was more than 3 times higher in Indigenous women, First Nations women, and twice as high in people living in remote and very remote areas. So there is still a significant equity issue in the population. And that's in relation to access to vaccine and to access to screening and treatment. HPV vaccine coverage, the goal is 90% of girls vaccinated by the age of 15, and where we're at, I have it slightly more updated, but it's about 85% for girls, again lower in Indigenous adolescents and those living in remote areas. And I won't go through screening and treatment just because it's not so relevant to this talk. But you can see here the coverage has declined slightly in the pandemic years and is slightly lower. On the left-hand side, you can see Indigenous females turning 15, about 83%, non-Indigenous females 85.5, and is a little bit lower again in Indigenous males at 78.1%, and in non-Indigenous males at 83.4%. But I think on a global scale, that is quite good coverage, given that it's been quite a long-standing program by now. It's also integrated with another adolescent routine vaccine, DTP, so quite a convenient vaccine to have introduced into the schedule, even for boys. And this is from our NCEARS coverage report showing 2021 versus 2022. You can see girls, then Indigenous girls in the red. You can see all boys and Indigenous boys in the middle. Oh, sorry, was trying to get rid of the little box at the bottom. And you can see then by areas of disadvantage. So the key take-home message for the Australian policymakers is that Indigenous girls and boys and those who are disadvantaged are lagging behind. And then from our National Department of Health coverage that they've reported, you can see here that they've reported in 2022, that's the 2-dose coverage, but this was the most recent coverage statistic I could find. So 2023, 85.9% for females, 83.4% for males, and that's 1-dose completion, which is all we care about now. And just to show you on the right-hand side, the trend, so this is actually the past is on the, 1996 is on the right-hand side, and we're coming towards the present, and you could just see that there was a gradual increase in coverage and there was a little bit of a dip. So this is from Australia's national strategy to eliminate cervical cancer. So as you can see, there's been those slight declines, but potentially still on track to be able to aim for elimination by 2035 if we can improve that coverage and if we can improve on the indicators, and with obviously a goal to expand to global elimination of cervical cancer. Just wanted to also highlight another unique component that Australia was able to contribute to in the HPV story is this the first country to be able to report active safety surveillance for the Gardasil 9 vaccine. So this is via SMS surveys to recipients of this new vaccine. And what they were able to report was that there were significantly higher local reactions and short-term adverse events following Gardasil 9 compared to the 4-valent vaccine, but obviously still not enough to outweigh the benefits of vaccination. And this is updated regularly. We maintain this active safety surveillance system for all immunisations, including those on the national schedule, as well as others like COVID-19. And you can see here that at that 12 to 13 years, girls and boys receive HPV and DTPA together, and very few of them need to see a doctor in the days after vaccination, less than 1 in 100. And historically, when they looked at when people had to go back for their second dose, which was just HPV, that was likewise less than 100. So extremely safe, well-tolerated vaccines. And some more data from Australia that is helping to establish the herd immunity that can be generated through high coverage of HPV vaccines. On the left-hand side, you can see for the proportions of genital warts diagnoses by age group in females. And on the right-hand side, we're looking at males. So what you can see is I'll get you to look at the right-hand side. Even during the period where only females were vaccinated, there was a decline in genital warts diagnoses in males. So you can see that there was some impact of herd immunity. And then, of course, with the gender-neutral vaccination period, that declined further. And so there's obviously population benefits of having high HPV vaccine coverage. And if you have gender-neutral programs with high coverage, that would also then confer some protection for girls, especially those who may be unable to access the vaccine. So now moving on to just a brief look at the global perspective. So the most recent data I could find of the WHO Clearinghouse HPV dashboard from September this year, 144 countries have reported that they have HPV included in their national immunisation program. Of these, 69 are vaccinating only girls in the national program, and 75 have announced programs for girls and boys. This doesn't specify funding or age range, but overall you can see the trends there. And this is showing you the number of countries that have introduced a single dose schedule. So you can see the single dose is in the orange, so it's North America, parts of South America, Australia, and some countries in recent years are now introducing the vaccine for the first time with just a single dose schedule, which is increasingly the trend. There's still a number of countries using two-dose schedules, and obviously there are challenges sometimes with making a nationwide off-label vaccine recommendation in certain settings, for example, where that's never been done before. So in the past 16 years, national HPV vaccination programs have been introduced, but global coverage overall remains low and varies by income status. This is from the PATH slide sets. You can see the link at the bottom below, and you can see in this graph, they're showing coverage comparing the high income countries to low income countries. And global coverage is about 1 in 4 worldwide, and only about 20% of these are individuals from low middle income countries. And likewise, from the same PATH slide set, there has been some improvement in global coverage to the pre-pandemic levels because of a focus on new vaccine introduction. Gavi is also prioritizing HPV vaccine, resumption of programs that were previously interrupted by supply issues, coverage improvement in selected ongoing programs, but urgent action is still needed to improve coverage and catch up missed doses. So you can see for one dose HPV, the darkest blue, we're looking at about 21% in 2022 for girls, and in the darker green for boys at about 6% in terms of global coverage. And I'm just disregarding the second one, which is HPV-C. That's for two-dose coverage where it's still used. And this I thought was just an interesting graphic from a paper that looked at the burden of cervical cancer relative to coverage estimates, and focusing again just on one dose of HPV. And the size of the squares here, and these are the acronyms are representing countries, is proportional to the annual number of new cases of cervical cancer. And what you can see is that the biggest population countries have fairly low coverage, and those countries that have very high coverage in the dark purple have a very low incidence of cervical cancer. And that, of course, could not solely be attributed to vaccination, but that would certainly be a contributor. And now looking at global coverage over time by income category and WHO region, unsurprisingly, there's higher coverage in high-income country girls and boys, and it's higher in those boys than in low middle-income country girls. And you can see here the distribution of WHO regions. And this came out updated fairly recently, a WHO document going through the vaccine choice options for HPV. And they've most recently added this new product, Walrin-Vax, which was qualified by WHO on the 2nd of August of this year. It's a bivalent vaccine. And they've also included in the same document, the link was on the previous slide, you can see here the availability of one-dose efficacy or immunobridging data, which means that countries can consider using at least these 4 vaccine where there's already efficacy data available to potentially introduce the vaccine for the first time as a single dose. And for this newer vaccine, there's immunobridging study planned. So supply and demand, as I mentioned, that's a big factor in the ability to vaccinate a larger population or to expand to gender neutral vaccination. Demand has, of course, been increasing and is forecast to increase further. And these slides are from a UNICEF presentation that I've linked below, just to show that in this current period that we're in from 2017 to about now, there have been supply constraints and there have been disruptions because of the COVID-19 pandemic, but the supply situation is improving and projected to soon meet demand. And this is a modeling study that had a look at the projected global vaccine demand in a few different scenarios. So I don't like when they use the same color for different lines in a graph, but the darkest green here at the bottom is a one-dose schedule. So if you just had a one-dose schedule for girls only, this would be the projected demand. If you had a one-dose schedule that was gender neutral, this would be the very light green second from the bottom. So you can see that introducing one dose but gender neutral is actually a lower demand than continuing with a two-dose schedule, which are that the third lightest green, I guess you could say. And then the very top one is if you're aiming for elimination of cervical cancer and only vaccinating girls, but trying to get enough coverage, that's about similar. But I think the take-home message, and apologies that I have to be quick. The take-home message is that gender-neutral vaccination is made much more achievable because of the option of having a single dose schedule. And again, just to show some projections here that the supply constraints are expected to be short term. So in a base case scenario, by 2025 to 2027, there is projected to be enough supply to cover one dose schedules and gender neutral vaccination. In the very short term, as in up to this year, this was not expected to be the case. But of course, if there are unexpected or future supply constraints, then those timelines could be pushed out further. So the take-home messages are from Australia that we have achieved relatively high coverage, but it could be better. It could do, obviously, the goal is to achieve 90% as per WHO target. In our gender-neutral HPV vaccine program, our coverage lags in First Nations and remote communities, and these communities must be prioritised. We've had a slight decline during the pandemic years. This must be addressed, but overall, good progress towards potential cervical cancer elimination. And globally, there's been increasing uptake of HPV vaccines around the world. This has driven great demand for the vaccine, and supply is projected to increase and soon be adequate to meet the potential needs. And single dose vaccination is a great strategy that can enable vaccination of a broader cohort, including males. So I'll stop there. Thank you.
Dr. Ketchama, thank you so much for those brilliant insights and thank you for moving quickly, considering our time constraints tonight. I will come back to you at the end and ask each of you, what is your overall take-home message? And you've really just set yours out, but there may be a single one that you wish to really work on. Dr. Tai Pham Quang, would you now please put your slides up and begin your presentation about Vietnam.
You can see my slide now?
We can.
Yeah. So thanks, Dr. Ketaki, for all of your information, because with your information, I will go fast because some of my slide will somewhat important idea from the Australia team. So here it's the presentation, and I will focus mostly on how we change the policy and something that we learn from the market. The HPV in Vietnam, long time ago, we always talk like the cause of the cervical cancer, and we focus on that. Even the name of the vaccine is a cervical cancer vaccine. But now we have to change the idea, because it's not just only the problem with the cervical cancer. It's many part of the body has to be affected of that. And EPI of Vietnam, we cannot have that much condition like what you see in Australia. We start from very minimum number of vaccine first, and then we put in some new vaccine for each year. However, HPV is not included into Vietnam EPI vaccine program yet. But beside with the national program, there is a vaccine on demand program. It means it is the pay. It is how to say for the market, the free market, and people have to pay for that. And from 2008, we already have the approval for the HPV vaccine into Vietnam. And people in Vietnam, they might come to the vaccine center outside of the EPI to get a vaccine. And we have the experience how to run that vaccine for quite some time before we try to input into the program. In Vietnam, there is the problem with the young people so far, because when we do a survey, we see that the school-based students have some problem related to the getting sexual very early. And when we ask them, many of them already have the sexual before age of 14. So and then with this time, the number even more than double of the time we compare, we do a survey in 2013, and it increased over time. So that is the problems. And in Vietnam, there is 3 kind of vaccine that already approved by the Ministry of Health. We have a Cervarix. It now somewhat stopped in the market, but the license is easy to get back into the system. We have a Gardasil 4 valence and the 9 valent also. Recently in 2019, 18, we have that. And we also learned the real evidence with 4 valent and 9 valent, and even in the free market, in the market, vaccine market now, it's both 4 valent and 9 valence is available, and the people have the right to choose. And during our consulting for the customer, they know about all the real world evidence from country like Australia, like Philippines, like Thailand, the US, the experience we have. And with that experience, we do consulting better, but only happen outside the EPI. For schedule choice, we also have the experience of presenting and counseling the people from a very early age. And we know that the most effective age is from 9 to 14, because at that time, we can catch up with the sex activity of the children early, so you can do the prevention better. And how about the schedule of the 1 or 2 dose? We have some problem that already in the present of the Dr. Ketaki already mentioned, that is off-label. In Vietnam, there's very difficult to apply something off-label. We need to have some approval, at least approval from Ministry of Health, or something, even approval of the prescription from the manufacturer before we can bring that schedule into the program. And so far, all of the vaccine in the EPI program is follow manufacturer prescription rather than off-label. So off-label is difficult. We learned that a single dose regimen could address a lot of things, like the supply problem, finance problem, the demand problem, and also even the facility and deliveries. All that good, but the only problem is off-label things. And the other thing we also think about is vaccination to boy or girl, because recently, if we use the 9 valent in Vietnam, we have the prescription for both boy and girl, but for 4 valent, there is only girl in the prescription. It is not changed yet in Vietnam approval. So vaccination for boy is also another thing. And what we learn from outside is, if we can provide the vaccine to both boy and girl, we can easier to get the control better with the HPV, because if we have only 80% coverage of the HPV in boy and girl together, we can easier to get eliminate for the virus. But if we only aim for women, we need to have at least 100% of the women vaccinated. that is something. But people still question, because 100% of the women is even lower than 80% of both. Yes, it is. But the neutral HPV is that, because we can prevent not just only the girl, but we prevent for boy also. And beside that, some people may think that if we use HPV that much, we can forget about other things. But no, for HPV, we learn that HPV, even we have a very good vaccination program, but still we need to focus on other things like this screening, like cancer service, like adolescent health, and many other things. So it take into account that with the HPV prevention, we not only just talk about vaccine. So the payment for that, some people question that, is that you trying to put the payment from the population pocket into the government pocket. I don't think so, because of the accessible of the vaccine is much more important. And we learned that many countries already set up the coordination between the committee and the national plan and many different things. And maybe we need to change the many other partner into the vaccine and into the prevention program. Here some model. I think that that real model coming from Australia also, that point out to us that not just only the girl-only vaccination, but girl-only vaccination plus screening plus the older age group also get the vaccine is better way to prevent, rather than we wait for only girl and we wait for that. And later on, I can show how it works. For the health economic, people always try to say, okay, now you move from the population pocket into the government pocket. So how is effectiveness? And this is the study conducted in 2020 about different scenario we are using, like no vaccine, like vaccine for HPV 4-valent only, like girl only, or girl or boy, or the different scenario of the coverage of the vaccine and other service for the cervical screening. And here what they show. They show that if we use the 2 doses of the 2-valent vaccine for girl only, we can prevent something like 100 deaths by 2,100. But it's long. It's effective. If we pay $1, we will get back $8 for the use of the vaccine. But with that schedule, we can come to achieve the elimination by 2084, very long. Maybe I'm passed away already. So that is the problem. And on that model showing that if we add some more issue in, like we can provide more vaccine for more people, we can provide vaccine for men and other things, the cost effective will reduce as you wish. But we can achieve the elimination faster. That is the model. So, and the price we compare here is about $6.5 per dose, or $15 per dose is also is cost effectiveness. But of course, the more expensive is lower in the cost effectiveness for the country. And one interesting things they showing out in this study is that they say vaccination for boy is not cost effectiveness. Okay, that is the way they are looking at the economy things. But for the faster of coverage and the faster of the cross protection, boy is important for the neutral things, neutral. And here is what they show. Besides with the population's pocket, we also say people will pay. And if that much of the people pay, you can see in comparison, if the payment for the vaccine only from the people, not from the government, we have to pay more, somewhat like 100 something US dollar for 1 dose. But still, we can prevent the estimated cost of the cervical cancer and many other things like surgery, like radiation therapy, like chemotherapy and magnetic. You can see the total number of the amount of money is much more higher than the cost. But people still questioning on that because that is the individual problem, not the government problem. So we have to convince them. We convince them by using the evidence from other countries around. Cambodia is one of that. Cambodia has the move HPV into their program since October 2023, 1 year before. And what they have, they have the Gavi Aglibo, and they get a good price, and they get the quick approval from the country. And so they just run with that. Vietnam is still waiting. And we can see further into one country nearby, the China. The population of the China consists of the cohort with most of the girls. in all around of our region. And what they do in China, they have their own vaccine. They have the vaccine, I think, 2-valent vaccine, and produced by Chinese company. But with all of the effort, they bring that to all school girl at grade 7 and age below 14 from 2021. And what they coverage, the vaccine coverage reached 89% by the end of 2022. Is great because of when we compare the number of girls each year, the cohort is a lot compared to other countries in the region. And with all of that public health campaigns, they have a lot of lessons that we can learn. That if the government have a strong decision and a strong leadership, they can have a very good, effective coordinating all other mechanism to get the vaccine into. And also they use a model, what we call is a school model, to give the vaccine. However, the country production is also a problem sometimes because of people maybe question about the vaccine from a local vaccine rather than see the good vaccine coming from outside. For example, is one of the things that the Chinese people question. In Vietnam, we also get that things, and we learn one thing, even we get the vaccine from outside, but the communication and education also very important because we have all of the experience that previously we have the connection with Park US. They run a pilot program and they give the vaccine to children around 6,000 girls around age 11 and with 3-dose regimen. And they do both school-based and community health-based. And you can see from the result coming out very, very good, like 96% or something coverage, very quick. People learn very quick on how the effective of the vaccine. They learn about the price, and they learn about if they can access to the vaccine, they can easily to access because they know about the experience from outside and also the experience from the market. That is a good thing because in Vietnam, we already run the vaccine in the market for quite some time, for 2008 until now. So with extra experience from the global, or like how to deal with the school-based delivery or school-based and also health facility delivery of the vaccine, we can succeed implement the vaccine. The only problem is if we can move that in, many other aspects of the HPV vaccination need to take into account because that is for the EPI is new. And here, can we use a 1-dose regimen because it is off-label, and like something like education, like working with the stakeholder, like long-term goal of the cancer prevention, or developing how to develop a new communication with a new material. I think it's still a lot of effort. And with all of that, I think it's most important to persuade the government like Vietnam. I think not just only the experience from a country like Cambodia or country like China or country like Australia. We keep saying about the NITAC, keep saying about experience, keep saying about how good the vaccine can provide. But when we say about that, we still need more support because the vaccine not cheap anyway. The vaccine is somewhat the question from cost effectiveness and question from how we can use this kind of vaccine into the national program along with the market. The on-demand program is still a question because even national program only provide the 4-valent vaccine, still a comparison with the 9-valent from the outside. So that is also a challenge in the very near future if we want to implement this vaccine into our program. So thank you for your listening.
Thanks very much, Dr. Tai. I do know that you do have to leave early, so I wonder if I can just ask you one question really about the one-dose regime. You've talked about the others. Do you think Vietnam will move towards the advantage of a single-dose system? And to what extent with boys and girls?
Yes, we learn. It's great because we learn from Australia experience. Because previously we say, okay, that is a regimen from the research. That is the information from Africa. Is not somewhere around. It's not the experience from developed country. But now we have the experience from Australia. But not just that. The EPI program now working with the company in terms of not testing, but in terms of preparing more evidence. Maybe we can run in the pilot program a small, somewhat similar like study, but it's not just study. We check with the small scale of the population with the one-dose regimen to see how Vietnamese people adapt with the one-dose regimen, and then after that, it can expand into nationwide. So I think it's a good step before we move into fully one-dose or two-dose regimen in final.
So take it step by step. Yeah. Thank you so much. We really appreciate it. We really appreciate your being part of this webinar training session. Can I move to Dr. Anthony Calibo from the Philippines? And if you can start your presentation, it would be brilliant. Thank you very much.
Thank you, Dr. Michael Moore. Good morning, good evening, good afternoon to all our listeners and those tuned also in social media. I'll be presenting the Philippines situation on HPV vaccination, current actions and challenges. I have no conflicts of interest to declare for this presentation. These are the objectives of my presentation, to discuss the current trends and status of HPV vaccination in the Philippines, share the challenges being encountered right now in the country, and also to share the future plans for HPV vaccination also in the Philippines. Our organization is JPIGO. This is an international non-profit organization, has been based also in the Philippines for almost 4 decades, but our head office is based in Baltimore, Maryland in the USA. We have technical expertise in 38 areas, which includes immunization, maternal and child health, including support for primary health workers. These are the current countries where we have immunization programs as well, including HPV and adolescent vaccination. The HPV Vaccine Acceleration Program Partners Initiative is an international consortium of 5 organizations, and JPIGO is one of them. And we're also in Kenya and Cote d'Ivoire, including Pakistan, where the Happy Partners Initiative is being implemented to support governments improve coverage, access to HPV vaccine and vaccination. This is a profile of the Philippines right now. We are an archipelago, and our current population is 114 million, of which 6 million girls aged 9 to 14. And for 15 to 19, we have 5.1 million. Being implemented in schools for the school-based immunization, which includes HPV vaccine, measles, rubella, and tetanus, diphtheria, toxoid. We have 43,000 public elementary schools, and current enrollment for 2024, we have 13 million children enrolled for kinder up to grade 6. The Department of Health is the national government agency that develops policies and programs, including vaccination. However, our health system has evolved in accordance to the local government code. Vaccines are being procured centrally by the Department of Health through its national immunization program, and it's funded by government appropriations enacted in Congress, signed by the President on a yearly basis. These vaccines are delivered at the subnational offices of the Department of Health or Centers for Health Development, and these are delivered to 38 city health offices of highly urbanized cities, independent component cities, and likewise 282 provincial health offices. HPV vaccines are delivered in both public and private sector. For private sector, these are administered by pediatricians, family medicine specialists, for pediatric population. Likewise, for adults, we have internists, OBGYNs, nurse midwives as well, and occupational medicines in certain work settings. There are also private schools wherein these vaccines are made available and administered by school physicians. However, in public sector, our immunization workforce, the ones administering are public health midwives under the supervision of medical officers or rural health unit physicians. And these are also supported by public health nurses. Barangay health workers are the ones that navigate families in the communities that remind them of immunization campaigns or programs happening in specific months, and likewise as catch-up vaccinations that may be called by the Department of Health or the local government unit. Clinics are the ones being done, settings for private sector. However, for public sector, this may happen also in pediatric clinics of government hospitals and infirmaries. However, majority of the vaccines and vaccination takes place in the 1,775 rural health units all over the Philippines, as well as 915 barangay health centers. Barangay health stations are satellite clinics that are built to address geographically disadvantaged areas in certain areas of the country. The vaccine was registered at the Food and Drug Administration of the Philippines in 2013. We have bivalent, quadrivalent, and 9-valent vaccine products currently in the market. The first HPV vaccination demonstration project was done in 2013, supported by the industry, MSD, in partnership with the Department of Health, Adolescent Health Program, Disease Prevention and Control Bureau. In 2013, 2 areas were selected. This is in Baguio City. Baguio City is a highly urbanized city found in the Cordillera in northern Luzon. And the other one is in Cebu Province in the Visayas in central Philippines. In the demonstration project, 3 doses were what was the regimen that was done. And coverage for 30,000 10-year-old girls was 95%. This demonstration project was used to analyze and plan for succeeding phased implementation, which took place in 2015, supported by government funds already in selected priority provinces based on high number of poverty or incidents. Up to the present, this is still the current setup using quadrivalent vaccine procured nationally by the National Immunization Program. We use 2 doses 6 months apart. Target population, grade 4 girls, who may be 9 to 10 years old enrolled in this grade level. And the other girls may coming in from age 9 to 14 may be tapped in community-based HPV vaccination program. For school years 2017-2019, pre-pandemic, officially the Department of Education was involved already. And this took to a halt during the pandemic for school year 2020 up to school year 2022-2023 due to school closures and partial opening status in many public elementary schools. Last October 7, 2024, the Department of Health and the Department of Education kick off what they call as Bakuna Eskwela or school-based immunization, which jump-started again the administration of measles, rubella, and tetanus diphtheria toxoid for grade 1 boys and girls, and HPV vaccine for grade 4 girls aged 9 to 10. The current status of HPV vaccination is still subnational, as there are still areas that are not yet fully implementing HPV vaccination. It is part of the national immunization schedule under the National Immunization Program, and it is also included in private sector pediatric immunization schedule. The Philippines has officially adopted a clinical practice guideline in February of 2024 for prevention of cervical cancer. And this also included already the single dose as an alternative dosing regimen for public health purposes. The NITAG, or the National Immunization Technical Advisory Group, has been newly created in September 2024. However, the efforts to start this started since 2018, however, did not push through because of many priorities that compete in establishing the NITAG. Currently, there are technical assistants coming in from the World Health Organization and JPIGO to support the NITAG Secretariat. Hopefully, this will become very functional already in the last quarter for this year. I will now proceed to the trends and status of school participation in the Philippines. In my earlier slides, I mentioned that there are around 40,000 public elementary schools under the Department of Education. Here we can see that from years 2015 until 2022, there are varying rates of participation, which means that out of the total number of public elementary schools found in these regions, this is only the proportion of public elementary schools that have been participating. Take note that it is not always 100%. Hence, this is going to be a challenge in making sure that we are able to cover as much grade 4 girls who received HPV vaccination. School years 2017, 2018, 2019 are the highlight of the institutionalized school-based immunization supported by the Department of Education in collaboration with the Department of Health. However, school years 2017 and 2018 have been known to have been affected by the public health incident on the tetravalent dengue vaccine that shocked the health sector in the Philippines. Hence, this might be also one of the reasons why these trends happened in those years as presented here. This is for Luzon, this is for the Visayas, and this is for Mindanao. Visayas and Mindanao were not that much affected in the tetravalent dengue vaccine public health incidents because the priority areas back then were only in Luzon, such as National Capital Region, Central Luzon, and Southern Tagalog, or Region 4A. However, because of social media and traditional media, this may have penetrated highly urbanized cities also found in the regions of Visayas and Mindanao. In this slide, I will now present to you the trends in HPV-1 coverage, HPV-2 coverage, and the 2-dose completion rate. We note that in 2015 to 2017, there was still a higher HPV-1 coverage. However, the second dose administration proved to be very difficult. Factors affecting this will mean that children may not be available anymore during the second dose administration. Either they were lost to follow-up, they were no longer enrolled in that same school, or they have probably transferred to a different school wherein that school were not involved in the HPV vaccination campaign. The second dose completion rate here tells us that completing the 2 doses has also been very low, and because there were only few vaccinees in school years 2015-2016, these were still manageable during that time. And pandemic years 2020, 2021 until 2022 have also seen decline in both HPV-1 and HPV-2, as well as the completion dose for the 2 doses required. This is now the information on the number of enrolled girls and the number of vaccinated girls only for a particular school year, 2022-2023, to provide a quick snapshot of what's happening in the regions all over the country. Regions 1 to Region 5 will be found in the mainland Luzon Island, including island provinces of the same geographic region. We note that the overall coverage is only 4%, and Regions 1 and Cordillera would have the only double-digit vaccination coverage. For the Visayas, the highest was found only in Western Visayas, which consists of the provinces in the Panay Island, that is this island group here, and the lowest would be found in the Eastern Visayas region. Eastern Visayas is one of the regions in the Philippines wherein there is still high poverty, incidence of poverty, as well as very frequent encounters with typhoons that may affect the routine immunization programs during the school year. And the last would be the island grouping of Mindanao. Region 9 is Zamboanga Peninsula. This is the Zamboanga Peninsula, which had at least the near 10% coverage and one of the highest as well found in the region of Mindanao. However, when we did sub-analysis of provinces, we found that these were the top 10 provinces that are implementing HPV vaccination in all of its municipalities and component cities. So to provide a graphical presentation of this, I am showing the next slide. On the left panel of the slide, you will find the Philippines map, and there are outlined boundaries in green. These correspond to the 10 provinces that are implementing in all of its municipalities or component cities. On the right panel of the slide, we can appreciate the province of Ilocos Norte, the northwest part, the province of Abra, and the province of Abra, and this is the province of Apayao. The highlighted municipalities in green will tell us that these are the bright spots, local government units that have achieved more than 80% vaccination coverage. The only municipality that made it in the list that had a high HPV vaccination coverage was the municipality of San Benito, the inset area here, which is found in Surigao del Norte. Surigao del Norte is an island province here in the eastern coast of the Mindanao island region. This next slide will tell us, is vaccine dose an issue that may lead to undercoverage of school-age girls aged 9 to 10 or grade 4 girls. We note that the Department of Health is not fully covering the total number of enrolled girls found in the first column for the year and the second column for the historical number of enrollees. It is only covering this number on the fifth column, wherein in 2015, out of the 1,124,000 girls, they only procured 650,000. This is the number of those utilized for a 2-dose regimen, because there were only 362,000 girls that were targeted by the program. Despite that, the utilization of the HPV-1 was only 90%, and HPV-2 was only 76%. However, there are still unutilized vaccines. Thus, in the last column of this slide, we will appreciate that through the years, the overall HPV vaccine utilization has not reached more than 90%. And there are always still unutilized vaccines that end up being carried over to the following year and being combined in the total procurement. So number of vaccines that can cover girls is not an issue. It's a matter of systems implementation. How can we effectively utilize this vaccine to reach more girls in a timely and efficient manner. So in summary, the challenges are, in the Philippines, HPV vaccination coverage is still low. HPV vaccination uptake is also low because of, as evidence in the schools, not participating as well. And this may be contributed by many factors. Number one is parents who receive the consent form may not be fully aware of the benefits of the HPV vaccination for their girls. Number two, teachers who are frontline personnel that distribute consent forms for parents may not also be able to provide adequate information or the facts known to make parents understand and fully make an informed consent. The utilization of HPV vaccine, as mentioned and shown in the slides that I have shared, and reporting and health information system is also very challenging to really capture the status of HPV vaccination coverage. Note that the statistics that I have shared came from the Department of Education because the official statistics coming in from the National Immunization Program may not provide also very disaggregated information up to the municipal or city level. However, the Department of Education was able to provide that. Partial implementation of the HPV vaccination program in the municipalities or cities, this is still a challenge because we need also political will and the support of local chief executives, particularly municipal and city mayors, and also what we call as village chieftains or barangay captains, and likewise other decision makers and policy makers at the subnational and national government. Hopefully, the low participation of public elementary schools will change now that there is renewed support coming in from the Department of Education, as evidenced in the recently launched school-based immunization campaign. What are the future plans of HPV vaccination in the Philippines? The National Immunization Program has applied for a technical assistance from Gavi for the middle income country strategy or MICS. The NITAG has been formed recently, and there is significant technical assistance to support the NITAG Secretariat. It is also being expected that the NITAG will include in its agenda the evaluation of the single-dose recommendation of the Strategic Advisory Group of Experts for Immunization, including discussion of age cohort of girls and to support decision-making and policy, and hopefully a national policy on the recommendation of NITAG on HPV vaccination in the Philippines. Because earlier issuances on HPV vaccination was only developed from the National Immunization Program without any experts' contribution similar that would happen in many countries where there is a technical advisory group. There's also interest and initiative to strengthen the immunization information system, particularly being included in the Field Health Service Statistical Information System, which will be managed by the Epidemiology Bureau. The last four plans are also here. The NITAB members are reportedly to benefit from a learning exchange in Australia. I think this is part also of the provisions in the Gavi mix. Also strengthening capacities on adverse events following immunization surveillance. The NCIRS has conducted a pharmacovigilance and an adverse event following immunization workshop last July. And we're thankful for the support of Australia's NCIRS for this. There's also provision of additional support from NITAG as discussed. And lastly, I'd like to share this information that through JPIGO, we have an HPV learning project to address health systems determinants funded by the HAPI. And we will be field testing the WHO behavioral and social drivers tool on HPV immunization funded by the Centers for Disease Control and Prevention in the United States. Thank you very much, and I hope we were able to get information from the Philippines HPV immunization program. Thank you very much.
Thank you very much, Anthony, and has been a very full and intense hour, I have to say. We did have one question in the chat, Anthony, specifically to you, but Kat, you might also like to buy in. What's the most effective communication message regarding gender-neutral vaccination? Is it about health equity, sexual transmission, accelerate cervical cancer elimination, or the vaccine to prevent anal orifice and so forth, conditions, cancers in boys and men? What do you think is the most effective communication method?
Dr. Michael, I would like to answer. Right
Please.
now, there is no program yet that includes boys in the HPV vaccination. I think the emphasis and thrust of the Philippine government is to reach more girls and to also stabilize probably vaccine procurement and the logistic management system to improve delivery as well. However, the experience of the Philippines, particularly with JPIGO, is that when we integrate communication campaigns, particularly addressing cervical cancer elimination, particularly on primary and secondary prevention, parents would have a meaningful appreciation that cervical cancer prevention takes more than just being screened, or will take more efforts apart from being vaccinated. However, vaccination is the first step. And in our social behavioral change communication strategies and materials that we developed to as part of our technical assistance to the Department of Health, when we field tested this to parents, there was a positive feedback, and they liked the materials, and they said that it will be very helpful in encouraging more parents for their girls to receive the vaccine. And they're also thankful that women or mothers are not neglected in the overall picture, because there is also equal emphasis to take care of mothers not to get cervical cancer in the future. That's my side. Thank you.
Thank you very much, Anthony. And I said I would, we're already over time, but I did say I would say, what's your one take-home message? So I'm going to go to Dr. Sharma, Kataki Sharma, for the take-home message. Then I'll come back to you, Dr. Kalibo.
Yeah, sure. I think I hope I made it clear in the talk. I think my take-home message is that single-dose HPV vaccination, it shouldn't be seen as an inferior alternative. As Dr. Tai mentioned himself, it's a WHO SAGE recommendation. It's been taken up by many high-income countries that hopefully improves confidence in this strategy. There is immunogenicity data now out to 16 years from one single dose. That's very reassuring, and I think that will be the enabler for more countries to plan for gender-neutral vaccination. Even if you're introducing it initially with the focus on girls, as per current WHO guidance, NITAGs can already be thinking ahead, and the other thing that NITAGs could play a role in is advocacy to government to create that mechanism for an off-label recommendation where it doesn't yet exist, because that is a great long-term strategy. There are many other instances where NITAGs can make effective off-label recommendations. And sorry, that's not just one take-home message, is it?
No. That was, I think that was very good, because those messages are really important. Dr. Kalibo, take-home message.
First, we'd like to thank the opportunity given to us and also my colleagues from the Philippine Society of Public Health Physicians. They're also happy that they were given the opportunity to field someone from the Philippines to participate in this one. We urge decision makers and policy makers all over the country, particularly in low middle income countries, and also that's also a call to action also to our colleagues here in the Philippines, that we need to revisit our current strategies and policies so that many girls will benefit from this, and hopefully our systems can be more efficient to deliver the vaccine, and we can appeal to many parents and many other stakeholders to unite and to work together for the benefit of all of these children. We can stop cervical cancer, we can eliminate it. Thank you very much.
And you're doing it step by step, I think, as Dr. Tai mentioned, but also taking that long-term vision where when it's affordable, when the circumstances are right, that our boys can be vaccinated as well internationally. Can I have the last slide, please, Maria? Because I think what I have to do is thank very, very much each of you, because it really has been a fantastic reflection on what's going on and how we might be able to improve things, because our real focus for all of us is to ensure healthier communities, and this is one way of doing it. So thanks to University of Geneva, the World Federation of Public Health Associations, and MSD for giving us this opportunity. And I now declare this meeting closed.
Thanks very much.
Thank you.